Last but not least, it is my pleasure to introduce Dr. Brian Gilberti. He's Assistant Residency Director at NYU and a member of the All New York City Board of Directors, where he is affectionately known as our tech wizard. And he is the reason that we have all been able to successfully transition our in-person conferences to the Zoom platform. So we owe him a debt of gratitude for that. So without any further ado, take it away, Dr. Gilberti.
Thank you, Jenny. I think it's a dubious distinction to be the Zoom expert, but I'll take it. And today we've talked about Wu-Tang, we've talked about Peloton. I want to touch on coffee and just one of the ways in which it relates to critical care. And a little less abstract, I want to discuss how we can improve our practice by deciding to go out with the new and in with the old. And to do this, I'm going to talk about a couple ways in which the old way of doing something may be the better way to do it. And the newer way kind of just doesn't really compare. And so taking a step back, our profession is one that really strives to inch forward. And with that comes this desire to welcome advances with the hopes that this will help our practice. And inch by inch, we have morphed ourselves from snake oil salesmen to true doctors. However, sometimes this desire and being on the bleeding edge of medicine can be a double-edged sword. And by that, I mean, with this drive, we can have some missteps that can degrade our care. And history of medicine is replete with these. I encourage everybody to look into the very troubling history of amiodarone for the treatment of stable VTAC, how it wasn't the first medication to treat it, and it's not the best medication to treat it. Nonetheless, it gained favor with some. But I don't want to talk about antiarrhythmics. Today is Crit Care Day, so I want to discuss a couple meaty critical care topics. And in order to do this, I want to propose 3 examples in which our care could be improved if we went back to the older way of doing something, and specifically how we administer epinephrine in cardiac arrest, how we evaluate for fluid responsiveness in septic shock, and lastly, how we treat family members during resuscitations and CPR. So say what you will about epinephrine. This could be a whole separate talk, but I think that it has its own redeeming qualities. And I'm a very simple man. When I give epinephrine, I want it to be in the patient's heart. And when it comes to this, where we establish access plays a really big role here and deserves a little more of our time to discuss. And we've all done this. Compression's ongoing, we drill in an IO, we spray our medications, but is this the best way to run a code? Are we giving our patients their best shot at making it out of this? And multiple studies have observed some of the outcomes that we care about, like ROSC and neurologic outcomes, that these are better with IO versus IV. And don't be mistaken, these studies are severely flawed. They're very flawed. With selection bias, with the IO group being sicker than the IV group, all this can't be ignored. But it should call into question whether we prematurely have adopted IOs for this purpose. And just think about it. I'm sure a lot of us have had easy IO reps come to our program, talk about their product, but do they ever talk about these outcomes, anything that we really care about? And this is not the only study. It's not perfect, like I said, or definitive, but it should prompt us to scrutinize this and ask ourselves, is this a step in the right direction? And in order to take a look at why this might be problematic, we should see where we're giving these medications. And when we put it into the tibial IO, and unless we're chasing it with 20 cc's of fluid or a pressure bag, these medications can fester. And also, we know in hemorrhagic shock that bone marrow blood flow decreased by 70 to 80%. So just think about what happens during cardiac arrest when sometimes the cardiac output is 20 to 30%. And lastly, when we put epinephrine into the bone marrow, that increases vascular resistance and reduces marrow flow. So a lot of things that could be problematic. And as is often the case, whenever we're confused or we're looking for some clarity and answers, we should look at our swine friends for some answers. And compared to femoral lines placed in pigs, only 53% of epinephrine given IO in the tibia makes it to the atrium, only half. So keep all this in mind. A crash fem may be the best way to get the right amount of the medications to the right spot, to the heart. Use an IO if there's no other access, but this should be a bridge and may not be adequate for access. So this is the first example where I suggest that we should take a step back and do it old school and maybe put in a crash fem during our resuscitations, our cardiac arrests. Next, I want to discuss monitoring fluid resuscitation. And here we really do walk a tightrope between underdoing it and overdoing it. Underdoing it where we may under resuscitate, whatever that means, or overdoing it where we can overload the patient, pulmonary edema in rare situations lead to compartment syndrome. So we really walk the line here with these patients in septic shock when we're giving fluids. And ultrasound has been proposed as a way of monitoring fluid responsiveness by evaluating the diameter of the IVC and looking at respiratory variation. And from that, we're able to come up with the Cavell index. And that's what's been studied extensively for this purpose. And there's a lot of heterogeneity here, a lot. And one thing that may be constant is that maybe we prematurely adopted and have had confidence in POCUS for this application. Now, I know we're all fearing the POCUS gods, and I want to be clear that I'm not anti-POCUS. But for this application, it may not be as fruitful as we'd hoped. But it's very confusing. What are we comparing it to, right? What's a cold standard? What are we looking at for comparison? Cardiac output, stroke volume, VTI. These are a couple of attempts, but in a way, we're kind of flying blind. And until recently, like last month recently, we got a better idea of how blind we have been with this meta-analysis that suggests that maybe it's not as good as we'd hoped. By the numbers, TT of the IVC to predict fluid responsiveness had a sensitivity of 74%, specificity of 83%, and an area under the curve of 0.68. So really not that good. So we're left by asking ourselves, well, what are we left with? I'm not going to say lactate because we're going to get it and we're going to get it again. But also here's another place where it may be better to keep it old school, or at least dedicate a little more time to the old school methods. So MAP, urinary output, heart rate, respiratory rate, listening for RALs on exam, how they look, their mental status. All these things put together, like Dr. Wilcox said, will help point us in one direction. They're going to be individual data points that we have to all put together. And lastly, and the most important point that I want to make in this segment is how we approach goodbyes in the emergency department. And it goes without saying that we deal with some of the most impactful moments in patients' lives. And with that comes a chance to dampen the echoes of grief for the rest of their family members' lives. So what we do in these minutes really do matter. Here's Lincoln on his deathbed, just to give you an idea what death used to look like. And yeah, we're not all Honest Abe. We're not all going to have this many people at our bedside when it's time. But it's just to give you an impression that you used to live with loved ones by your side and die with loved ones by your side. And it really entered into the sphere of debate in the 80s with this paper in 1986 published in the Annals. And I want you guys to look at the title of this paper, that family participation in resuscitation was an option, as if this were something novel to have family in the room during a resuscitation. And if you look at this paper, there's some really sad testimonials in it that highlights the fact that these are moments that can't be erased. And since then, the issues come more into focus, with the first high quality data emerging in 2013 with this prospective cluster randomized trial. And yeah, it's not apples to apples, orange to oranges, but family presence during CPR, which is what they looked at. And they also looked at if that had an effect, an impact on PTSD related symptoms 90 days out. And what they found was yes, it did. When they called these family members 90 days afterwards, they saw that they had significantly less PTSD-related symptoms, anxiety, and depression. And all these bonds between family members are pregnant with meaning. First kiss, watching your son's first steps, tucking them in at night, walking down the aisle. All these relationships have countless layers of meaning, emotions, and memories that are sacred and indelible. So who are we or administrators to say that, well, only one member of the family can come in when somebody's sick? And I wish I could say that this is current practice to offer family into the room. And I think that that was generally the case, but COVID has made us take a step in the wrong direction, in my opinion, by restricting who we allow at the bedside. And sadly, these restrictions still linger in most places with just one guest being allowed in. And we have to acknowledge that these decisions that are made very far removed from the bedside and far removed from the hearts that beat for the ones that stop. But now that we in healthcare have access to vaccines and a better understanding of this illness, I encourage us to go back to how we used to do it and how we used to treat our sick patients and their family members by allowing their family members in, and not just one member, to be at the bedside, to hold their hand, to witness, to say goodbye, and to embrace each other in grief, and to inch closer to closure. And if that goes against the rules, then we got to break them. We got to rip it up and do what matters, do what's right. So deep breath. Let's do a recap here, how we can improve our care for the critically ill patient. First, access is access, but not all access is the same. And when you run a code, maybe a crash FEM will be better than a tibial IO. In fluid resuscitation and septic shock, one of the most basic aims still eludes us, and looking at the IVC may not be as fruitful as we had hoped. Looking at the more traditional measures of responsiveness may be better. And finally, the common denominator of what we do in medicine, in ER, when we come to work, is to reduce suffering in the world, whether it's through our patients, through their loved ones, through their family members, and they won't get these moments back. So if people are critically ill, don't let them be critically ill alone. And if it's their time, let their family, not just one member, be there by their side so that they're not alone. And through this, we can take a step forward by taking a step back. Thank you.
Wow, what a thoughtful and meaningful and poignant end to our conference today. It's so true. What is old is new again, and our patients and their families, they need us to be present for them, and the patients, the sick and dying patients, need their families to be present for them. That was so meaningful. Thank you so much, Brian. And with that, everybody, I am so grateful that you joined us for this conference today. We had such a fabulous time sharing our speakers and holding company with you. We miss you, and we so look forward to the next time we're able to all be together, which I feel so hopeful that it's going to be sooner rather than later. We would be remiss if we didn't spend a second to pay appropriate thanks to Dr. Duncan Grossman, who not only provided 2 sensational curbside events, but he also was part of the production crew of today's conference. Dr. Brian Gilberti, who just gave us that really meaningful talk and is the tech wizard in the group. Dr. Eric Steinberg, one of the board members and group organizers. Brian Gilberti is also a board member, but Dr. Steinberg, also fabulous talk and part of the production crew. Dr. Jenny Beck Esme, being excellent as she always is, and Dr. Kestel Riopel for our graphic design. Thanks so much to the All NYCEM Board of Directors for providing cutting edge, collaborative education. And I truly am grateful for you for your mentorship. Thank you so much for joining us. Thank you.